Hello friends, I'm Dr. Abhishek Nouduri and here I am back with my new video on clinical snippets from medicine. Friends, our recent NEET and AIMS examination have emphasized more on integrating medicine with pharmacology, physiology and pathology. The more we integrate, the better we can perform in any competitive exam. So the basic theme is we'll get a long clinical scenario and then we'll need to identify what is the pathophysiology of the disease, what is the neurological features of the disease, what is the drug of choice for the treatment. So we'll see a few cases from neurology perspective in this session. And my dear friends, neurology is very important for the upcoming NIMHANS examination and as well for the MAIMS examination. So let's get started. A 15-year-old boy is brought to the OPD by his mother with the chief complaint of difficulty in walking. The child enjoys playing football, but he had to leave the team due to his progressively worsening symptoms. On examination, he is found to have significant kyphoscoliosis and a high plantar arch. His elder brother suffered from a neurological disorder and died of heart failure at a very young age of 25. The patient has which one of the following neuropathological findings? So, my dear friends, this is the format of NEET. You will get a long clinical scenario and then you are asked about the neuropathological findings so that you need to integrate your knowledge of medicine and pathology. Again, my dear friends, whenever we get a long question, we need to emphasize the keywords. 15-year-old boy, difficulty in walking. Progressively worsening symptoms, so it is insidious onset. On examination, he is found to have significant kyphoscoliosis and a high plantar arch. So, a disorder of anything related to the congenital anomalies with significant systemic features like kyphoscoliosis, skeletal manifestations, and high plantar arch, that is pes cavus. And again, his elder brother suffered from a neurological disorder and died of heart failure at a very young age of 25. So, there is similar history in his sibling, and he died of sudden cardiac death or heart failure. So, what can be the neuropathological finding in the child? So, the options are atrophy of the caudate nucleus, cerebral cortex atrophy, degeneration of the spinocerebellar tracts, demyelination of the peripheral nerves, loss of neurons in the anterior horn cell of the spinal cord, loss of neurons in the substantia nigra. So, my dear friends, we'll discuss about the neuropathological findings of each of the diseases involved and then we'll try to correlate it with the clinical findings of the disease. So, here we saw a boy with progressively increasing weakness and we saw kyphoscoliosis was there and also pes cavus was also there. And again, there was a sibling history with the same history, and he died of sudden cardiac death. So, what can you suspect, my dear friend? It can be a disorder of autosomal dominant inheritance, since both the generations are affected and both the siblings are affected. So, I'm thinking of an autosomal dominant disorder which is having slowly progressive symptoms and it is associated with skeletal abnormalities and pes cavus, and it is also associated with hypertrophied obstructive cardiomyopathy, or as I said, the most common cause of sudden cardiac death is obstructive cardiomyopathy. So, cardiac arrest in a young child, you must rule out HOCM unless proved otherwise. I discussed these points in my video on sudden cardiac death, my dear friend. So, you can refer to it as well. So, atrophy of the caudate nucleus. What is the disease involving the atrophy of the caudate nucleus? My dear friends, what is it? It is Huntington's chorea. Cerebral cortex atrophy. What is the disease involving cerebral cortex atrophy? Again, my dear friends, this is very important. You need to know the neuropathological findings of each of the neurological diseases involved. It is Alzheimer's disease, and the most common symptom of Alzheimer's is dementia. So basically, here the answer will be degeneration of the spinocerebellar tracts. As we saw, he has progressively increasing weakness and there is ataxia. So degeneration of the spinocerebellar tracts. The disease we are discussing here is Friedreich's ataxia. It is the classical disease associated with skeletal abnormalities, that is kyphoscoliosis and pes cavus, and there is hypertrophied obstructive cardiomyopathy, and it is the most common cause of sudden cardiac death unless proved otherwise. Again, my dear friends, I would like to emphasize here one more thing. Sudden cardiac death in athletes all over the world is HOCM. Sudden cardiac death in athletes in Western countries, When the history is pertaining to Western countries, it is HOCM. And the gene to be tested is beta-myosin. Yes, my dear friends. And sudden cardiac death in the Asian population, in Asian athletes, more commonly is when the question specifically asked about India or Southeast Asia, it has to be Brugada syndrome. It is due to defect in the gene sodium channel SCN5A gene mutation. Again, my dear friend, in this way, you must integrate the topics. Whenever you hear about Brugada syndrome, you must memorize the ECG findings of Brugada syndrome. What are the ECG findings of Brugada syndrome? Code pattern HT elevation in leads V1 to V2 and in an otherwise normal individual with recurrent attacks of palpitations and syncope. So HT elevation is not only MI in pericarditis, in Brugada syndrome also we can get HT elevation. I have discussed in detail about all these in the topic of sudden cardiac death. But like I said, you should integrate the topics you have read one day before, 1 week before, and 1 month before. Your revision should start from the day one itself. Then only you can excel in any competitive exam. So let's discuss in detail about each of the options. But firstly, we'll discuss about Friedreich's ataxia. So, my dear friends, as I already said, in Friedreich's ataxia, there is peripheral neuropathy. There is degeneration of the spinocerebellar tract, the posterior column. What are the sensations carried by the posterior column? Again, this is a very important physiology question. Vibration, pressure, stereognosis, fine touch, all these are carried by posterior column sensations. Scoliosis and pes cavus are the skeletal abnormalities. Scoliosis and pes cavus are the skeletal abnormalities seen in Friedreich's ataxia. HOCM is the most common cause of sudden cardiac death in a patient with Friedreich's ataxia. And due to peripheral neuropathy, there is element type of lesion and it is leading to gradually increasing progressive motor weakness. So, the tracks involved in Friedreich's ataxia are the dorsal root, which carries the fine touch, vibration, proprioception, and pressure sensations, and the lateral corticospinal tract, which leads to UMN type of lesion below the level of the spinal cord, and the dorsal spinocerebellar tract, which leads to ataxia. Again, my dear friends, ataxia is a sign of cerebellar symptom. Again, you must be aware of the cerebellar symptoms. What are the signs and symptoms of a cerebellar disease? You will see that ataxia is seen and dysdiadokinesia and drunken gait or reeling gait is seen in a patient with cerebellar disease. You must be able to differentiate between these two, cerebellar disease and the involvement of spinocerebellar tract. So, again, there are two more diseases in which these are the three columns which are exactly involved. The one is the most common one in India, vitamin B12 deficiency or subacute combined degeneration of the spinal cord. My dear friends, if they ask you a question, the most common cause of subacute combined degeneration of spinal cord or the degeneration of the posterior column and the lateral corticospinal tract, then you must answer it to be vitamin B12 deficiency. Like I said, common things are said to be common than the rare thing. If you make a common diagnosis, you'll be commonly correct. In a country like India, B12 deficiency is more common. So, B12 deficiency causing subacute combined degeneration of spinal cord, leading to the degeneration of the dorsal root, lateral corticospinal, and dorsal spinocerebellar tract is very important cause of the degeneration. Another disease involving the tree tracts is tabes dorsalis, which is involvement of the spinal cord in syphilis and Friedreich's ataxia. So, my dear friends, Friedreich's ataxia is an autosomal dominant disorder, is an autosomal recessive disorder. Again, my dear friends, you will be confused in this way. Friedreich's ataxia is autosomal recessive, whereas Huntington's chorea is autosomal dominant. So, you must be able to differentiate between the two. Like already said, in Huntington's there is dementia and he presents with coriform movements. What are coriform movements? They are dancing like movements. But in this patient, there were no coriform movements. There was simply ataxia and progressively increasing weakness of the lower limb and upper limb, and there is skeletal deformities of kyphoscoliosis and pes cavus. So, autosomal recessive disorder caused by the mutation of the frataxin gene FXN gene. This gene codes for an essential mitochondrial protein involved in the assembly of iron sulfur enzymes. So, why it is important? It is important because it is involved in the pathogenesis of the disease. An increased number of GAA repeats are present in the gene, causing decreased FXN expression. So, my dear friends, increased number of trinucleotide repeats, GAA repeats, is very important in the pathogenesis of Friedreich's ataxia. Again, Importance of trinucleotide repeats. I'll emphasize them in the next slide. Friedreich's ataxia, the repeats accumulated are GAA. Huntington's chorea, the repeats accumulated are CAG. There is a mnemonic to remember it, my dear friends. Huntington's chorea, think of the hunter, and the hunter always comes with a cage. So cage, CAG repeats are more commonly accumulated. Tonic dystrophy, T, though it stands for CTG repeats. Friedreich's ataxia. Ataxia A, it stands for GAA repeats. Again, my dear friends, these are the common mnemonics made by myself. So you should also remember these by your own mnemonic, so that these trinucleotide repeats are at your fingertips, and they are a must question in any entrance examination. So, increased number of GA repeats leading to essential mitochondrial protein dysfunction, and then it leads to decreased mitochondrial energy production. Like you'll read in your biochemistry, mitochondria are very important for oxidative phosphorylation of aerobic respiration. So, there is increased oxidative stress leading to the degeneration of the neural tracts and the peripheral nerves. So, there is degeneration of the three tracts, like I discussed. There is spinocerebellar, dorsal column, and lateral corticospinal tract. There was a previous NEET question: which of the following is not involved in Friedreich's ataxia? And it is anterior corticospinal. So there can be a question in this way as well. So there is peripheral neuropathy as well as degeneration of the lateral corticospinal tract. So basically, three tracts are involved: spinocerebellar tract leading to ataxia, dorsal column and dorsal root ganglia leading to loss of proprioception and vibration. Again, my dear friends, there are five sensations which are chiefly carried out by the posterior column. These must be at your fingertips. They are proprioception, vibration, fine touch, and stereognosis, and also pressure sensations. So basically, five sensations carried by the dorsal column, whereas the lateral spinal tract causes spinothalamic tract carries the sensations of pain and temperature. Anterior spinothalamic tract carries the sensations of crude touch. So these are very important, my dear friends. These sensations carried by the sensory parts must be at your fingertips. Lateral corticospinal tract leading to spastic weakness. Kyphoscoliosis and foot abnormalities like pes cavus are characteristic skeletal deformities. So, ataxia or progressive weakness with kyphoscoliosis and pes cavus, first you should think of Friedreich's ataxia. Heart involvement includes hypertrophied obstructive cardiomyopathy. Again, the gene involved in this is beta myosin. But here, beta myosin is not responsible for HOCM. I wanted to discuss this point at this juncture, my dear friends, because HOCM beta myosin gene is more commonly tested. But HOCM can be caused by the mutation of other genes as well. And here it is beta myosin, here it is frataxin gene mutation. So ataxia with spinocerebellar tract involvement, and with kyphoscoliosis and pes cavus, the first thing you need to think is Friedreich's ataxia. And HOCM here is not due to involvement of beta myosin. Diabetes mellitus develops in 10% of the patients. So Friedreich's ataxia patients are increased risk of development of which of the following endocrine abnormality? And it is diabetes mellitus. So, like I already said, my dear friends, trinucleotide repeat sequences are a must question in any entrance examination. HD, Huntington's chorea. Hunter carries a cage always, so it is CAG repeats. Myotonic dystrophy. Tonic. T is the thing you must highlight in your mind, so it is CTG repeats. Again, Fragile X syndrome. It is CGG repeats, where G is to be highlighted. So, Huntington's chorea, CAG, myotonic dystrophy, CTG, Fragile X syndrome, CGG. And again, Friedreich's ataxia. Like we said, Huntington's chorea, myotonic dystrophy, Fragile X syndrome are all in the non-coding regions. So they start with C and end with G. Friedreich's ataxia is an exception. It starts with G and ends with A. Friedreich's ataxia. You must remember it like this. You must pronounce it like this. Ataxia. So it is GAA repeats. So Huntington's chorea, CAG repeats. Myotonic dystrophy, it is CTG repeats. Fragile X syndrome, it is CGG repeats. And Friedreich's ataxia, I is to be stressed upon, and it is GAA repeats. Trinucleotide repeats is a very important question. Again, I'm emphasizing, my dear friends, so that you must memorize them. Like they must be at your fingertips. CAG repeats, you first think of Huntington's chorea. The first thing that should strike your mind is Huntington's chorea. So they must be at your fingertips. You do not need any logic to remember this. Some things are need to be remembered and you should follow them strictly. Again, my dear friends, here I would like to emphasize the importance of the 20th notebook here. Apart from your 19 subjects, have a 20th notebook to have the emphasis of the must read topics, the must memorize topics in every subject, and keep the 20th notebook along with you all during these days of preparation, and it will make you the it will make you ahead of your competitors, because the 20th notebook is going to be a game changer for you in the last 1 month of your preparation. So believe me, my dear friends, the must memorize topics you must write down and you must read them separately, so that you cannot use any logics to remember them. So you must memorize them by any way, and you can try silly mnemonics and you can try your own mnemonics to remember them. So Huntington's chorea is CAG repeats, myotonic dystrophy T is CTG repeats, Friedreich's ataxia is GA repeats, Fragile X syndrome, the stress upon G, it is CGG repeats. All these start with C and end with G. They are present in the non-coding regions, and Friedreich's ataxia GA repeats. It is present in the coding region. Let's look at the other options now, my dear friends. Huntington's disease. It is an autosomal dominant disorder. Again, my dear friends, Friedreich's ataxia was autosomal recessive. Huntington's chorea is autosomal dominant, characterized by CAG repeats. Hunter always carries a cage with him, so it is CAG repeats. In the Huntington gene, which results in severe neuronal loss of the caudate nucleus. So the first option of atrophy of the caudate nucleus pertains to Huntington's disease. Again, my dear friends, Hunter always carries a cage. We made this mnemonic in a similar sense in one more subject, that is biochemistry. To differentiate between Hunter syndrome and Hurler syndrome, we remember as if the hunter, as he has to hunt, his eyes has to be clear, so there is no corneal clouding in Hunter syndrome, but there is corneal clouding in Hurler syndrome. Hunter cannot be mentally retarded, so mental retardation is absent in Hunter syndrome, while mental retardation is present in Hurler syndrome. So corneal clouding is absent, you must think of Hunter syndrome. These are lysosomal storage disorders, and it is also very important for you for the AIMS examination. So, Hunter, the mnemonic itself has been used twice. Hunter always carries a cage. So, CAG repeats in Huntington's chorea. Hunter cannot be blind. So, corneal clouding is absent in Hunter's disease and lysosomal storage disorder. Huntington's disease manifests with dementia, behavior abnormalities, and coriform movement. What are coriform movements? Again, your physiology is very important, my dear friends. Coriform movements are rhythmic, regulatory, oscillatory movements, or simply dance-like movements. And Huntington's chorea most commonly presents with dementia and behavioral abnormalities. So, again, my dear friends, you must integrate your knowledge of medicine with anatomy and physiology as well. This is a kernel section of the brain, and we can see that this is the caudate nucleus, and these are the lateral ventricles. Lateral ventricles have anterior horn, posterior horn, and an inferior horn, which is not visible here. So, there's atrophy of the caudate nucleus, and by the law of physiology, whenever there is atrophy of the caudate nucleus or the nuclear matter, the adjacent ventricles expands. So this is the disease where we can see the expansion of the ventricles. This is sometimes referred to as the boxcar ventricle. Again, my dear friends, you must be able to identify the caudate nucleus in this picture. These are the caudate nucleus. When there is atrophy of the caudate nucleus, you can see that there is enlargement of the subsequent ventricles, which can be a potential MCQ in anatomy as well as in radiology. So in this way, you must integrate your knowledge of medicine with anatomy and radiology and pathology whenever possible. Atrophy of the caudate nucleus enlarge anterior horns of the lateral ventricle. So what are the horns of the lateral ventricle enlarged? They are the anterior horns. What are the horns which are not involved? It is the inferior horn. So again, my dear friends, we saw that there is atrophy of the caudate nucleus. This is a patient of a This is a CT of a normal patient, my dear friends. And in this case, there is enlargement of the lateral ventricles due to atrophy of the caudate nucleus. So you can see enlargement of any ventricles, then it means the adjacent gray matter or any nuclei have gone atrophied. This is an important sign in radiology, my dear friends. So you must be able to appreciate it. Again, my dear friends, this is CT or MRI. You must be able to differentiate between CT and MRI just by looking at them. This is NCCT showing enlargement of the frontal horn of the lateral ventricle. Again, my dear friends, why is it CT? because you can see that here the bone is clearly demarcated and is white in color. Just as in X-ray, in CT as well, the bone is white in color. So it is CT as the bone is very well appreciated. You must be able to make simple differences between CT and MRI just by looking at the image, and this you'll gain only by practice. So this is a NCCT. CT as the bone is white, showing atrophy of the caudate nucleus and enlargement of the anterior horn of the lateral ventricles. Again, option number B, cerebral cortex atrophy occurs in Alzheimer's disease and Pick's disease. Again, my dear friend, you must be able to correlate between Alzheimer's and Pick's disease. Alzheimer's disease is characterized by diffuse mild cortical atrophy and progressive memory loss. So, diffuse atrophy and progressive memory loss is Alzheimer's disease, whereas Pick's disease causes frontotemporal atrophy, illustrated by behavioral and emotional liabilities. So, I'm sure, my dear friends, you'll diagnose a Pick's disease as he comes with behavioral changes and emotional disturbances first, and you'll diagnose a case of Alzheimer's disease while he comes with the symptoms of memory loss. So, you must be able to differentiate clinically between memory loss and the patients of behavioral abnormalities. Alzheimer's disease has no partiality or bias, it affects the entire brain as a whole, whereas Pick's disease it affects the frontotemporal atrophy, and Pick's disease is also known as frontotemporal dementia. So, what is this CT or MRI, my dear friends? What is this CT or MRI? Again, you must be able to correlate. There is no thick white bone here, and the white matter appearing here is not bone, my dear friends. It is not thick, it is fat. Fat appears white on MRI. So, this is an MRI showing with T2, T1, and FLAIR images showing characteristically atrophy of the frontal and the temporal lobes. My dear friends, you can appreciate it clearly. There is bias in the atrophy with characteristically involving the frontal and the temporal parts of the bone of the brain. So it is characteristically frontotemporal dementia or the Pick's disease. So it is MRI showing frontotemporal dementia or the Pick's disease. Again, my dear friend, I would like to use this as an opportunity to differentiate between T1 and T2 weighted images. So this can be asked as a potential question in your exam. Which is T1 weighted image and which is T2 weighted image? My dear friends, you can see these are the ventricles. This is the lateral ventricle. These are the ventricles. So in these ventricles, if the CSF, CSF flows through this ventricle, the water ventricles CSF is usually referred to as water. Water is white in T2 weighted image. So this is characteristically T2 weighted image where you can see the CSF as bright white, whereas here the CSF is dark. So water is white in T2 weighted image. So this is classical to represent this. My dear friends, water is white in T2 weighted image and white matter is white in T1 weighted image. White matter is white. These are the white matter fibers. The white matter is white in T1 weighted image. Water is white in T2 weighted image. Again, my dear friends, there can be a twist in this question. Here the white matter is dark as it is a T2 weighted image and water is white as it is T2 weighted image. But if the intensity of water is decreased and water appears dark in T2 weighted image, then it is known as flare. I purposefully introduced these three images here to differentiate between T1, T2, and flare images. So you can clearly see water is white in T2 weighted image, water is dark in T1 weighted image, and when the intensity of water is decreased and it appears darker, then it is flare. Why is flare image used? Flare is exclusively used to detect edema in the brain so that the intensity of water is decreased. So, how is frontotemporal dementia or Pick's disease different from Alzheimer's disease? In Alzheimer's disease, all six forms of tau proteins are expressed, whereas in Pick's disease or frontotemporal dementia, only one isoform of tau protein is expressed. In addition, the presence of neurofibrillary tangles that are hallmark of Alzheimer's disease are absent in Pick's disease. Again, my dear friends, Alzheimer's disease, if you read your Robbins second year textbook, then you'll see there are two characteristic findings. Those are intracellular neurofibrillary tangles and extracellular amyloid plaques. And the severity of the Alzheimer's disease correlates with the inclusion of amyloid or neurofibrillary tangles. It is neurofibrillary tangles, my dear friends. Amyloid can be normally deposited in the brain, but the severity of the disease correlates with the amount of neurofibrillary tangles accumulating within the brain. So it is the neurofibrillary tangles which are important in Alzheimer's in deciding the prognosis. But they can be done only in the postmortem diagnosis, that is in the brain biopsy patient. But theoretically speaking, the amount of neurofibrillary tangles are more, then the disease is more severe. Another difference is that in Pick's disease, a personality change occurs before any form of memory loss. So the person becomes irritable and emotional disturbances are seen. There is as such no memory loss. You will be stunned by seeing the MRI that is frontotemporal atrophy without any memory loss. Unlike in Alzheimer's disease, where memory loss typically presents first, this is used clinically to differentiate whether a patient is suffering from frontotemporal dementia or Alzheimer's disease. Again, my dear friends, uh, both are in both the diseases there is tau protein accumulation, but neurofibrillary tangles is characteristically seen in Alzheimer's disease. Again, my dear friend, this is the normal ventricle. We can see on the left side, we can see that this ventricle is absolutely normal, whereas on the right side, what you can see is that this ventricle is atrophied with no bias, and all the lobes of the brain are equally involved. So there is diffuse atrophy of the cerebral cortex, and that is Alzheimer's disease. Again, my dear friends, you must be aware of two histopath findings of Alzheimer's disease from your pathological knowledge. The one is neurofibrillary tangles, and the other one is amyloid plates. Again, you can see you must correlate your anatomy here. There is hippocampal atrophy, which is seen in Alzheimer's disease. Hippocampal atrophy. You must be aware what parts of the brain are present in different situations. You must be able to identify, correlate the anatomy and the radiology. In previous NEET as well, pineal gland was asked as a question giving them MRI of the brain. So, hippocampus, you must know where is it located, what are its relations to the third ventricle, structures related forming the floor of the fourth ventricle, structures forming the anterior wall and the floor of the lateral ventricle, structures forming the lateral wall of the third ventricle. You must be aware of all of them, my dear friends. So, in Alzheimer's disease, the very first part of the brain which is involved is hippocampal atrophy. Again, this was a previous AIMS question. Hippocampal volumetry is the first test you need to do in a patient of suspected to be Alzheimer's disease, because there is hippocampal volumetry. In hippocampal volumetry, you will see that there is loss of hippocampus and subsequent enlargement of lateral ventricle closer to the hippocampal region, and that is used in assessing the volume of the hippocampus. So, hippocampal volumetry in the coronal plane is the investigation of choice to diagnose early cases of Alzheimer's disease. But like I said, as the disease progresses, it involves all parts of the brain in an equal way, and there is diffuse cortical atrophy. Again, my dear friends, not like frontotemporal dementia, the frontal lobe in Alzheimer's disease is affected at the last. So there is dementia presenting at first, and behavioral abnormalities are usually not common in Alzheimer's disease. Whereas in frontotemporal dementia or Pick's disease, the behavioral abnormalities were seen first. What are these? Like I said, the picture shows there are neurofibrillary tangles. These neurofibrillary tangles correlate with the severity of the disease. So the intracellular neurofibrillary tangles correlate with the severity of the disease, and these are characteristic and pathognomic of Alzheimer's disease. And option D, these are extracellular amyloid plaques and they do not correlate with the severity of the disease. This was a potential psychiatric question 3 years back in NEET. Amyloid plaques are accumulated in Alzheimer's, but they do not correlate with the severity of the disease. Again, Charcot-Marie-Tooth disease. We saw that there's one option pertaining to Charcot-Marie-Tooth disease. It is an autosomal dominant disorder caused by the demyelination of the peripheral nerves. Typical finding includes peripheral muscle weakness and atrophy with sensory deficits. So, Charcot-Marie-Tooth disease is an important clinical snippet in point of view of peripheral muscle weakness and atrophy with sensory deficits. Cardiomyopathy and kyphoscoliosis are not characteristic of Charcot-Marie-Tooth disease. But, but, my dear friends, pes cavus and hammer toe can be seen in case of Charcot-Marie-Tooth disease. So you can see that in Charcot-Marie-Tooth disease there is pes cavus, but kyphoscoliosis and HOCM are not seen in Charcot-Marie-Tooth disease. So this is the classical clinical snippet demonstrating the Charcot-Marie-Tooth disease. There is muscle imbalance producing high arch foot or pes cavus, and there is disproportionate pull on the muscles, causing weak pull of the tibialis anterior muscle and strong pull of the peroneus longus, leading to hammer toe. This is the hammer toe in Charcot-Marie tooth disease, and this is the pes cavus which is being demonstrated in the disease. So this is an important clinical snippet, my dear friends. Charcot-Marie tooth disease is also an autosomal dominant disorder, like Huntington disease, whereas Friedreich's ataxia was autosomal recessive. Typical findings include peripheral muscle weakness and atrophy with sensory deficit. Cardiomyopathy and kyphoscoliosis are not seen, but pes cavus can be seen in Charcot-Marie tooth disease. So, hammer-toe plus pes cavus, you must first think of Charcot-Marie tooth disease. In this way, my dear friends, we must importantly identify the keynote or the highlights of each clinical disease so that you can easily reach the diagnosis just by seeing the keywords. Loss of neurons in the anterior horn cells of the spinal cord. This was also one of our options, my dear friends. Loss of neurons in the anterior horn cell of the spinal cord occurs in poliomyelitis, resulting in flaccid paralysis, atrophy, areflexia, and muscle fasciculations. Again, my dear friends, what is upper motor neuron and lower motor neuron? Everything pertaining to the neurons above the anterior horn cell of the spinal cord is upper motor neuron lesion. Everything below the anterior horn cell is lower motor neuron lesion. Again, this is an important Viva question. Where is the anterior horn cell lesion called? It is an upper motor or lower motor? Yes, my dear friends, it is lower motor neuron lesion, and there is loss of neurons in the anterior horn cell in polio, causing a lemon type of paralysis, leading in flaccid paralysis, atrophy, areflexia, and muscle fasciculations. Again, my dear friends, there is a popular disease which affects the anterior horn cell of the spinal cord. Can you name what is it? Popular disease which affects the anterior horn cell of the spinal cord, presenting with features of both UMN and LMN, presenting with features of both spasticity and flaccidity. It is none other than, yes, my dear friends, this is the disease pertaining to the ice bucket challenge, and it is amyotrophic lateral sclerosis. So, damage to the neurons anterior horn cell of the spinal cord occurs in amyotrophic lateral sclerosis. Both corticospinal tract and anterior horn cells are involved in amyotrophic lateral sclerosis, popularly known as ALS. Loss of neurons in the substantia nigra occurs in the Parkinson's disease, which manifests with bradykinesia, rigidity, and tremor. This is a very important clinical question, my dear friend. Loss of neurons in the substantia nigra, dopaminergic neurons in the substantia nigra occurs in the Parkinson's disease, which is loss of neurons of substantia nigra occurs in the Parkinson's disease, which more commonly manifests with rigidity, bradykinesia, and tremor. So the classical triad of Parkinson's disease is rigidity, bradykinesia, and tremors. The classical pill rolling tremor. So that's what we discussed in the first clinical snippet. Let's go to the second question. A 25-year-old male is hospitalized with suspected tetanus. He sustained a minor lower extremity wound 1 week ago. Which of the following is most important in making this patient's diagnosis of tetanus? The first one is history and physical examination. Option B is blood culture. Option C is serum toxin assay. Option D is rising antibody titers. And option E is neuroimaging studies. So, my dear friends, how do you diagnose a case of tetanus? You need not know the clinical features or the any kind of microbiological findings or any highlights of tetanus. This is a clinical question, and how do you make a diagnosis in this patient? Yes, my dear friends, all of you might feel from your microbiology that blood culture is the standard for the diagnosis of tetanus. Even I used to think in the same way, like blood culture is the gold standard and the most important in making diagnosis. But no, my dear friend, you cannot make a diagnosis of tetanus by blood culture. It is purely and purely the history and the physical examination which are the most important in making the diagnosis of tetanus. So, it is the history and physical examination which is more important than blood culture in making the diagnosis of tetanus. Let's see why. Diagnosing tetanus requires strong clinical suspicion and a good patient history and physical examination. Culture of various specimen types does not frequently yield the organism, but may take several days. Remember that Clostridium tetani will only be found locally at the wound in which they are inoculated. So, the patient may wash off the wound and the organism may travel retrograde inside the wound and may not be found at the wound site, and so your culture might be negative. So, culture is not the gold standard in diagnosing a case of tetanus. On history, it is important to determine the immunization status of the patient and the length of the time since the last tetanus vaccine has been taken. In adults, booster of immunization is recommended every 10 years. So, it is very important to determine the immunization status of the patient in a case of tetanus, as the immunization status is very important in determining whether the patient is susceptible to the tetanus infection or not. So, a strong clinical suspicion and a good history is all that is needed to diagnose a case of tetanus. Additionally, the route of entry of Clostridium tetani is usually trauma. For example, a piercing wound, a burn, an illicit drug abuse, a contaminated soil, or a motor vehicle accident. So, a recent history of penetrating trauma is most important in determining the diagnosis of tetanus. Physical examination may reveal masseter muscle spasm, that is, trismus or lockjaw, facial grimacing, risus sardonius. Again, my dear friends, this is a classical clinical snippet and a very important visual based question. How does risus sardonius look like? How does lockjaw look like? Extension of the truncal muscles resulting in opisthotonous posturing. So, there's classically opisthotonous posturing and tetanus poisoning. Again, my dear friends, by your forensic knowledge, what is the other toxin which causes spastic type of paralysis and opisthotonous posturing? It is strychnine poisoning. So, tetanus and strychnine cause spastic type of paralysis. What is the poison causing flaccid type of paralysis? It is botulinum. Yes, my dear friends, botulism inhibits the cleavage of snare protein and inhibits the release of acetylcholine, thereby causing flaccid paralysis. So, flaccid paralysis in botulinum toxicity and spastic paralysis in tetanus and in strychnine poisoning. So, this is the classical clinical snippet showing rhesus sardonicus or lockjaw, where the patient is grimacing with pain. Blood cultures are not much of any use in the diagnosis of tetanus, as the disease is caused by the toxin released from the local wound infection, and it is the organism which is not important for the diagnosis. The organism is infrequently isolated from blood, and when it does grow, it will take 2 to 3 days to identify. So, you cannot just wait for 2 to 3 days in diagnosing a case of tetanus. It is very lethal and it has to be diagnosed with strong clinical suspicion and history. Patients with tetanus require immediate treatment based on a presumptive diagnosis based on history and physical diagnosis and physical signs. So, presumptive diagnosis and immediate treatment has to be there in tetanus as it is a fatal and the patient you can lose the patient in 2 to 3 days. There is no serum toxin assay available for making the diagnosis of tetanus. There is no antibody test available for making the diagnosis of tetanus. So, only history and clinical examination is useful in diagnosing a case of tetanus. Again, my dear friends, in this case, you need to integrate your knowledge of microbiology with medicine so that you should know that not only blood culture, a clinical suspicion and history are as useful and as important in making a presumptive diagnosis of tetanus. Again, by going deep into microbiology, we must know the key findings of Clostridium tetani. It is a gram-positive organism, anaerobic organism, and it is forming a spore-forming organism. It classically causes subterminal spores, causing drumstick appearance of the organism. So, gram-positive organism appear pink, and gram-negative organisms appear blue. You must know it by identifying the image itself. So, it is gram-positive organism classically showing the subterminal spores. And again, it is very important microbiological findings of Clostridium tetani. It is important theoretically as it causes swarming on blood agar and stormy fermentation of the litmus milk. So, swarming on blood agar and stormy fermentation of the litmus milk, gram-positive anaerobic organism with drumstick appearance on the gram stain. Again, my dear friends, there can be potential image-based question. What is swarming on blood agar look like? Why is swarming produced? Swarming is produced as Clostridium tetani is mobile by Peritrichus flagellae. And what are the agents you can add to inhibit the swarming? What is stormy fermentation of the litmus milk? What is the color of the litmus milk? All these can be potential image-based questions. So, in this way, you must take your microbiology notes and read about Clostridium tetani more so that you can integrate medicine and microbiology and you will be revising a part of microbiology in medicine itself. So, this is where all the funda lies. The integration is the key in learning any topic in medicine. Neuroimaging studies will not assist in making the diagnosis of tetanus. Imaging studies of the brain can help in making the diagnosis of other clinical diseases like Toxoplasma gondii. a CNS infection in leading to intracerebral abscess in immunocompromised patients. So, Toxoplasma gondii, classical ring-enhancing lesions in a patient with HIV with CD4 count less than 200. Less than 200, this was an important question. Ring-enhancing lesion producing headache and seizures. Seizures are rare in toxoplasma, but headache is more commonly seen in AIDS patients. So you must suspect headache with immunocompromised individual and MRI showing ring-enhancing lesions. You must first rule out toxoplasma gondii. Cysticercosis caused by Taenia solim is also diagnosed by CT scan. The pork tapeworm leading to inflammatory CNS cysts, as well as other signs of bacterial and fungal cause of intracerebral or epidural abscess, you can diagnose by neuroimaging studies. So tetanus has no role. There is no role of neuroimaging in the diagnosis of tetanus, but neuroimaging is the prime for the diagnosis of toxoplasma and cysticercosis. Cysticercosis cases are very common in India. Like I said, you must touch upon the common cases first and then think of the rare cases. So, common case of cysticercosis, you must be aware of the CT and MRI findings. Clinical snippet 3. A 53-year-old male complains of difficulty walking and right lower extremity weakness. Stroking the sole of the right foot with a pen elicits toe extension. Which of the following additional findings is likely to be seen in this patient? Option A, muscle atrophy. Option B, muscle fasciculation. Option C, cogwheel rigidity. Option D, hyperreflexia. And option E, positive straight leg rising test. Again, my dear friend, clinical questions are key in the NEET or next examination. So, difficulty in walking out, and there is right lower extremity weakness. Striking the sole of the right foot with a pen elicits toe extension. So, striking the sole of the right foot, what is this test known as? It is Babinski test positive, as there is toe extension is seen. So Babinski is a sign of upper motor neuron type of lesion, and in upper motor neuron type of lesion, there is more muscle atrophy and muscle fasciculation. Muscle atrophy and fasciculations are features of lower motor neuron lesion. Cogwheel rigidity. What is cogwheel rigidity? Where did you hear of it? Yes, my dear friend, it is Parkinsonism. Again, going to pathology of Parkinsonism, there is loss of dopaminergic neurons of the substantia nigra, leading to classical triad of rigidity, bradykinesia, and tremors. Again, my dear friend, this is the classical triad of Parkinsonism: rigidity, bradykinesia, and tremors. Positive straight leg rising test. Where does this come from? Where did you listen about straight leg rising test? Where did you hear SLRT? Yes, my dear friend, it is used in the diagnosis of sciatica or intervertebral disc compression. Let's see about each one of them. So the answer here has to be hyperreflexia, which is a sign of upper motor neuron type of lesion, and toe extension is Babinski sign positive, which is also seen in upper motor neuron type of lesion. So the answer we select here is hyperreflexia. Striking the plantar surface of the foot from the lateral heel to the heel of the foot is what is known as plantar reflex. Again, my dear friends, Babinski positive is toe extension or dorsiflexion of the toe, but the normal plantar reflex is plantar flexion of the toe or the simple flexion of the toe. Let's see in the images. Plantar flexion is a normal response. An upper motor neuron lesion will cause dorsiflexion of the toe, that is, the toe going upwards. So, striking from the medial to the lateral ball of the toe, starting from the ball of the toe to the laterally is plantar reflex, and negative Babinski reflex is curling of the toes. That is a simple plantar flexion of the great toe and curling of the other toes. Whereas in Babinski positive, there is a dorsiflexion, that is, toe is withdrawn towards the upper side, occurs in the absence of descending inhibition. Again, my dear friends, Babinski is normal in infants but pathological in adults. As there is defective myelination in the infant, and so Babinski is normal in infants and pathological in adults. As the myelination is not complete in infants, Babinski may be elicited in infants and it is not pathological. Lower motor neuron lesions cause muscle atrophy, fasciculations, and loss of tendon reflexes. Cogwheel rigidity, like I said, is a classical sign of Parkinson's disease. It is pulsing resistance to limb movement appreciated on physical examination and the classical triad of Parkinsonism is bradykinesia, rigidity, and tremors. A positive SLRT or straight leg rising test is a sign of sciatic nerve compression at the level of L4S3. SLRT or straight leg rising test is the most sensitive test for intervertebral disc prolapse causing sciatica. So let's see how is SLRT performed. So this is the test of SLRT, my dear friends. There's flexion at the thigh and extension at the knee. The test is positive when the pain occurs in less than 60 degrees of hip flexion. Again, my dear friends, less than 60 degrees of hip flexion, if the pain occurs, it is due to sciatica. So, how is the test performed? During SLRT, the L5 and S1 nerve root either moves or passively deforms. Maximum tension is realized in the sciatic nerve at 30 to 70 degrees of elevation from supine position. Crossed SLRT. Again, my dear friends, this was a potential repeat question. Crossed SLRT is the surest sign of intervertebral disc prolapse and pathognomic of micromotion in the affected nerve roots while rising the normal leg. So, 40 degrees suggests impingement of protruding intervertebral disc in a nerve root. Greater than 40 degrees indicates tension on the nerve root. More commonly, pain is seen between 30 to 70 degrees of hip flexion. Again, my dear friend, more than 70 degrees we can cause pain in any normal individual as well. So, up to 70 degrees only, this test is to be performed, and more commonly, to be on the safer side, we do it up to 60 degrees only. Again, my dear friends, clinical snippet number 5. A 45-year-old woman is brought to the emergency department after an episode during which she abruptly lost consciousness and had rhythmic jerky movements of the limbs followed by period of confusion. The patient had mild daily headache associated with nausea that had progressed over the last 2 years. The headaches are worse at night and occasionally awaken her. The patient reports no head trauma, visual changes, weakness or numbness, or difficulty swallowing or speaking. So, this is a long clinical scenario, my dear friends. You must be able to identify the key words in this question. 45-year-old woman lost consciousness, had rhythmic jerky movements of the limb. That is, seizures were also present. Mild headaches, which were worse at night. There is no head trauma, so you can rule out hemorrhage as in this case. There is no visual change or signs of compression, so tumor is unlikely in this case, and the headache being insidious in onset, tumors are most commonly not so much insidious in onset. Tumors I mean here are malignant tumors and not benign tumors. Benign tumors can cause mild headache. So headache in an elderly female like premenopausal or perimenopausal female increasing at the night time. So the first thing I think of is meningioma. As in meningiomas are more commonly in female of the reproductive age group or perimenopausal, and so the headache is usually mild and they enlarge and they worse at night, so I think of meningioma first. Like I already said, you must think of the common things first, then you think of the rarer things. She does not use alcohol or illicit drugs. There is no family history of seizures. An intracranial mass is discovered on neuroimaging, and biopsy of the mass is shown in the image below. Again, my dear friend, he is not giving the radiological image, he is giving the pathological image. So, a correlation between pathology and radiology in medicine is a must. A neuropathological correlation will only yield a diagnosis in this case. So, classically, what do you find in this patient? Again, my dear friend, don't get baffled by seeing the image. We already found out that it is a female in the reproductive age group coming with headache, which is mild. And there are no signs of raised ICT, and there are no signs of head trauma, and there are no signs of impending malignant tumor, and there is no weight loss. So malignancy is ruled out. And here also, there is you can exhibit a bit of horals in the histopathological findings. So horals plus these are laminar eosinophilic inclusions. What are these called? These are characteristically samoma bodies. So eosinophilic samoma bodies with horror patterns, classically female with headache is meningioma. So firstly, you must think of a presumptive diagnosis based on history and strong clinical suspicion. Then you see the histopathological image. Don't get baffled by seeing the histopathological image. Histopathology is difficult for any one of us, but histopathology plus history will give you the definitive diagnosis of the disease. So, oral pattern plus some of our bodies is meningioma unless proved otherwise. So female with headache, first think of meningioma as the headache is mild. And again, my dear friend, there's important tip for you. Meningioma is more common in females and meningioma has progesterone receptor positive. So tumor increasing in size in pregnancy is meningioma. And again, my dear friends, can you name one or another tumor which is progesterone receptor positive? So progesterone receptor positive tumor was meningioma. The second tumor is pecoma. Yes, pecomas in the lung are also progesterone receptor positive. So, which of the following is the most likely diagnosis? Like I said, the answer here is meningioma. But I'll use this as an opportunity to discuss about each one of the brain tumors, my dear friends. That is craniopharyngioma, presenting with suprasellar calcification; ependyoma, it is the aggressive tumor presenting in the lateral ventricular mass; glioblastoma multiforme, aggressive tumor of the adults, presenting with butterfly-like tumor; medulloblastoma, like we already said, it spreads by CSF drop metastasis. The answer here is meningioma. But let's use this as an opportunity to discuss about neuropathological findings and the radiological findings of each of the tumors at one go. So this is the classical image showing oral pattern and some over bodies in a patient of meningioma. You can classically appreciate the orals here, my dear friend, and you can also appreciate the lamellar eosinophilic inclusions, which are the samoma bodies. So, the patient biopsy findings are consistent with meningioma, a slow-growing benign tumor. The headache was mild, derived from meningothelial cells of the arachnoid. Note the oral pattern of the cellular growth that forms cell nests which may calcify and appear as rounded eosinophilic structures called as the samoma bodies. So, which are the other tumors where samoma bodies are seen? We'll come to discuss this in the next slide. Again, my dear friends, papillary tumors and the tumors with whorls show samoma bodies. This is a classical tip, my dear friends. You do not memorize the entire list of the tumors with samoma bodies. Anything coming with papillary tumor of the ovary, papillary cystadenoma of the endometrium, papillary cystadenoma of the ovary, papillary thyroid carcinoma, papillae, anything where the papillae are seen, Warthin's tumor, where there is cystadenoma papillomatosis in salivary gland. So whenever you see the word papilla, the tip of the papilla gets necrosed and calcium gets accumulated within this necrosed part and it may be appear as samoma bodies. So any tumor where there is papilla in the word, there is samoma bodies. And any tumor with whorled pattern, whorls in the histopathology, that is meningioma and mesothelioma. These are the tumors with samoma bodies. So tumors with samoma bodies, again, my dear friends, you just need to apply your mind here. Any tumors with the word papillary, papillary carcinoma thyroid, papillary carcinoma of the ovary, papillary variant of the carcinoma endometrium. All these tumors with the word papillae are associated with this samoma bodies. Again, Warthin's tumor, the other name of it is Warthin's tumor is cystadenoma papillomatosis. So Warthin's tumor is also associated with samoma bodies. And again, the tumors with whorl pattern, that is meningioma and mesothelioma, are also associated with samoma bodies. Meningiomas are well-circumscribed, rounded masses attached to the dura and are commonly found at the falcine. So, well-circumscribed, rounded masses attached to the dura commonly found at the phalluses of the brain. Classical image of the meningioma is that of a dural tail sign, a tumor which is away from the brain, well circumscribed, lobulated, classically showing the dural tail sign. Seizures can occur due to the compression of the adjacent cerebral cortex. We have seen the patient suffering from mild seizures, and in the history also there was a history of seizures. Headache, nausea, and vomiting may result from raised intracranial pressure, which further worsens during recumbency and with night time due to increased intracranial volume. Again, my dear friend, you must be aware from your physiology knowledge that intracranial volume increases during sleep, while there is hypoventilation during sleep and there is hypercapnia causing to vasodilation and increased blood flow to the brain. Whenever there is increased intracranial volume, the intracranial pressure also increases and thereby headache worsens at night. Headache increases during pregnancy as the meningioma is progesterone receptor positive. Headache worsens during night as there is increased intracranial volume and intracranial pressure at night time, so that headache is worsening at night. These are the important physiology questions that must be at your tips. Again, my dear friend, this is classically well circumscribed extraaxial tumor with characteristic dural tail sign. It is a classical spotter for you, and it is meningioma. So, the second tumor that we are discussing is craniopharyngioma. Craniopharyngiomas most often present as benign suprasellar tumors in children, and the most common presenting complaint of the children is precocious puberty. So, child coming with precocious puberty and you see a suprasellar tumor with calcification in the brain, the first thing that should strike your mind is craniopharyngioma. Grossly, it appears as a cyst with dark motor oil fluid consistency. Again, my dear friend, this question is theoretically important because mescaline oil or motor oil like fluid like consistency is seen in craniopharyngioma. It appears as cords or nests of palisading squamous epithelial cells. So, palisading is characteristically seen in craniopharyngioma, and this is true palisading seen in craniopharyngioma, and you must be able to differentiate with pseudo-palisading seen in medulloblastoma. Again, my dear friends, these questions are important only theoretically. History and clinical suspicion are more important, and when they are asked to identify the neuropathological imaging, then you can use this knowledge to eliminate the options. So, true palisading is seen in craniopharyngioma and also acoustic neuroma or schwannoma. So, acoustic neuroma or schwannoma, craniopharyngioma, there is true palisading, and pseudo-palisading due to necrosis of the epithelial cells is seen in medulloblastoma, with internal areas of cystic degeneration, calcification, and xanthogranulomatous reactions with giant cells. So, again, my dear friends, due to cystic degeneration and xanthogranulomatous reactions, there is cyst with dark motor oil fluid consistency. So, classical image of the patient, MRI of the patient showing, sorry, CT of the patient. Again, my dear friends, you can clearly identify this is the CT of the brain with suprasellar calcification. Again, my dear friends, CT is the investigation of soil to detect calcification of the brain. So, child presenting with precocious puberty and suprasellar calcification, the tumor is craniopharyngioma unless proved otherwise. So, this is classically the true palisading seen in a patient with craniopharyngioma. Again, my dear friend, you can see the lipoid xanthogranulomatous reaction within it, but the hallmark of this is the true palisading of the epithelial cells. Tumor number 3 are ependymoma. Again, my dear friend, classical ventricular tumors present as paraventricular tumors, floor of the fourth ventricle, and have characteristic perivascular rosettes. So, rosettes in pathology are very important. I'll come to discuss about them in the next slide. As they are intraventricular tumors, they block the blood flow of the CSF, and they can lead to raised ICT and hydrocephalus in children. So, features of raised ICT and hydrocephalus are marked in ependymomas, and they are aggressive tumors of the childhood. So, characteristic perivascular true rosettes are seen in ependymomas. So, this is classically a tumor within the lateral ventricle of the brain. Again, my dear friend, this is not the common location of ependymoma. Ependymoma is more commonly located in fourth ventricle. So, classical tumor within the fourth ventricle, ependymoma with classical T1 weighted image with contrast. Again, my dear friends, how can you identify whether it is T1 or T2 weighted image? You can see that the white matter is dark in this color. Water is white in T2 weighted image, whereas it is dark in T1 weighted image. So it is T1 weighted MRI showing classically fourth ventricular tumor, which is ependymoma. So you can see the classical characteristic perivascular rosette. Again, have a look at the lumen, my dear friends. If the lumen is clear and empty, then it is ependymoma. So, if the lumen is clear and empty, then it is true rosette. False rosettes are the rosettes which are filled with fibrillary tangles. The false rosettes are Homer white rosette and Flexner Wintersteiner rosette. Tumor number 5. Glioblastomas are the most common primary malignant brain tumors in the adults. They are most often located in the cerebral hemispheres and may cross the corpus callosum, characteristically giving rise to the butterfly glioma. So, glioblastomas crossing the midline and classically giving rise to the butterfly gliomas. Glioblastoma multiforme is the most aggressive tumor, and the prognosis in these patients is usually poor. They cross the midline and compress the adjacent structures, and there are signs of surrounding edema, and they are aggressive tumors, and they are classically known as butterfly gliomas. Light microscopy shows hypercellular areas of atypical astrocytes bordering regions of necrosis. Again, my dear friends, this is not true palisading by epithelial cells. It is atypical astrocytes bordering areas of necrosis, so it is known as pseudopalisading. True palisading was seen in acoustic neuroma or schwannoma and classically craniopharyngioma. Child presenting with precocious puberty and supracellular calcification is craniopharyngioma. So this is classical glioblastoma multiforme crossing the midline with butterfly appearance, and this is the classical description of a pseudo-palisading. You can see this area is entirely necrosed and the typical astrocytes growing up together to form pseudo-palisading. If it was formed by true epithelial cells, then it is known as true palisading, which is to be seen in craniopharyngioma. Medulloblastomas are the malignant cerebral brain tumors that typically occur in children. Typical location of the medulloblastoma is in the cerebellum. Again, my dear friends, we also saw one more tumor which was common in the fourth ventricle, and those were ependymomas, and are characterized by small round blue cells that may surround neutrophils, forming Homer bright rosettes. Again, my dear friends, true rosettes were seen in ependymomas, whereas in medulloblastoma, Homer bright rosettes are seen. Not only in medulloblastoma, any other peripheral neuroectodermal tumor, that is PNETs, any other peripheral neuroectodermal tumors, you can see small round blue cells with Homer bright rosettes. That is in neuroblastoma. Child presenting classically with abdominal mass which is calcified, not crossing the midline, and which classical metastasis to the eyes, it is neuroblastoma. So both in neuroblastoma and medulloblastoma, which are PNETs, peripheral neuroectodermal tumors, there are small round blue cells with Homer bright rosettes. So again, my dear friends, it is classically medulloblastoma involving the entire cerebellar region in both coronal and sagittal section. So you can see these are the tumors of the cerebellar vermis, and these are most commonly found in the cerebellum, and they spread by CSF drop metastasis. So cerebellum, tumor of the cerebellum in the child, which is quite malignant, spreading by CSF drop metastasis, is medulloblastoma. Again, my dear friends, you cannot see a clear lumen accumulating between the rosettes, so it is classically pseudo-rosette, and it is Homer right rosette seen in medulloblastoma, whereas true rosettes are seen in ependymoma. So Homer right rosette seen in medulloblastoma, Flexner-Wintersteiner rosette seen in retinoblastoma, true rosette seen in ependymoma. Again, my dear friends, rosettes are very important in pathology and also in correlation with neuropathological images. So I'm emphasizing one more time, Flexner-Wintersteiner rosettes are seen in retinoblastoma. Again, my dear friends, you can remember it by simple mnemonic R. Flexner ends with R. Wintersteiner ends with R. So R starting is retinoblastoma. Homer right rosette is seen in medulloblastoma, and right doesn't end with R, so it is seen in medulloblastoma, neuroblastoma, and all the peripheral neuroectodermal tumors where there are small round blue cells with Homer right rosettes. Again, we saw true rosettes in ependymoma, classically presenting with ventricular mass tumor and features of CSF obstruction and hydrocephalus. Perivascular pseudo-rosettes can also be seen in ependymoma. So let's have a look at the images of these rosettes so that we can identify them clearly. So this is a rosette, my dear friends. When the central lumen is empty, it is known as a true rosette, and true ependymal rosette is seen in ependymoma. This is a Homer right rosette, my dear friends, where there are neutrophils in the center of the Homer right rosette. So, cytoplasmic processes are forming the center of the rosette in Flexner-Wintersteiner rosette. R rosette ends with R, so it is seen in retinoblastoma. Homer right rosette is seen in PNETs, that is medulloblastoma and neuroblastoma. Medulloblastoma, child with cerebellum plus rosette, whereas in neuroblastoma, child with abdominal mass and calcification spreading to the opposite kidney, opposite adrenal, and spreading to the other parts of the body, especially orbital metastasis, are common in neuroblastoma. Perivascular pseudo-rosette with the blood vessel coming in the lumen can be seen in ependymoma. So true rosette seen in ependymoma, Homer right rosette seen in medulloblastoma and neuroblastoma, Flexner Wintersteiner rosette seen in retinoblastoma. So classically, one more time, you need to identify the image. Central lumen empty, so it is true ependymal rosette. Perivascular rosette can be seen in ependymoma. Homer right rosette, where you can see the central lumen filled with neutrophils and central lumen filled with short eosinophilic processes. It is none other than Flexner Wintersteiner rosette seen in retinoblastoma. Child with leukocoria and strabismus and Homer Flexner Wintersteiner rosette, the diagnosis is retinoblastoma. So I'm trying to clinically correlate with the neuropathological findings, my dear friends, so that the question can be asked in either way. They can give the clinical findings and ask you the diagnosis. They can give you the neuropathological findings and ask you the clinical findings. So you must be clear about the both of them and you must integrate them in this way. Tumor number 6. Pilocytic astrocytomas are usually benign tumors that involve the cerebellum in children and young adults. Again, my dear friends, one more tumor involving the cerebellum. Benign tumor involving the cerebellum is pilocytic astrocytoma, and malignant tumor of the children involving the cerebellum is medulloblastoma. Tumor cells typically have eosinophilic granular bodies and elongated hair-like processes, eosinophilic hair-like processes known as rosenthal fibers, which can be seen under microscopy. So, pilocytic astrocytoma is classically a cystic tumor involving the cerebellum, whereas we saw for medulloblastoma, it was having a malignant component and it was spreading into surrounding brain tissue and it was compressing the surrounding brain tissue, whereas this is a classical case of pilocytic astrocytoma. These are the rosenthal fibers seen in pilocytic astrocytoma, hairy, elongated, eosinophilic processes. These are the rosenthal fibers. Tumor number 7 is oligodendrogliomas. Typically involve the white matter of the cerebral hemisphere, and tumor cells have a fried egg appearance, rounded nuclei surrounded by a halo of clear cytoplasm, and chicken wire-like vascularity under light microscopy. Again, my dear friends, patient, young adult presenting with features of headache and raised ICT, presenting with fried egg appearance of the colonies and chicken wire-like vasculature. The classical tumor is oligodendroglioma. So classically, you can see the fried egg appearance, my dear friend. This is a very important image and very crucial image. Fried egg appearance of oligodendroglioma with adjacent vascularity in between the tumor cells. This is chicken wire-like vascularity. So fried egg appearance of the tumor with chicken wire vascularity is oligodendroglioma. Again, my dear friends, you must correlate clinically with what you see in the microbiology. So here, fried egg appearance in pathology is oligodendroglioma, and also in hairy cell leukemia, you can see the fried egg appearance. And fried egg appearance in microbiology, classically seen in the colonies of mycoplasma. So classically, fried egg appearance of colonies are seen in mycoplasma. Again, my dear friends, you must integrate in this way the knowledge which you have applied in medicine with your microbiology and pathology. Then only you will be able to revise number of times and then it will become easier for you in the final revision. Last tumor, which is the schwannomas. Schwannomas are mostly benign tumors that commonly arise from the vestibular branch of the cranial nerve 8 at the cerebellar-pontine angle. There are only two tumors common at the cerebellar-pontine angle, schwannoma or acoustic neuroma. Light microscopy reveals spindly cells with palisading nuclei, arranged called as verrucous bodies, composed of eosinophilic cores, which is known as Antony A pattern. Again, my dear friends, don't get baffled by the language of the question. Antony A and Antony B pattern are the two patterns which are seen in schwannomas. Antony pattern A is the one which is crowded with the cells. So it is known as Antony pattern A crowded with the cells, and verrucous bodies are seen in Antony A areas. Antony B pattern is the pattern where there are few cells. So in light microscopy you can see the classical palisading and with Antony A and Antony B areas and verrucous bodies. Again, my dear friends, histopathology is not at all important for diagnosis. Only history and clinical examination are very important. Child with sensory neural hearing loss and features of tinnitus and vertigo presenting with a tumor at the CP angle. You already got the diagnosis. It is acoustic neuroma or schwannoma. Just need to be more clear about the neuropathological findings. So classically, you can see many cells are seen in the eosinophilic area, blue cells. These are the nuclei of the cell. So it is Antony A areas, and here this Antony B where the cells are scanty. and classically you can see the verrucate bodies in the Antony areas. So, my dear friends, we have looked at about 10 tumors in the single question. I took this as an opportunity to correlate your clinical knowledge and neuropathological findings. So, let's have a quick revision or a quiz for you on what all we have learned. So, firstly, child coming with cerebellar tumor plus rosettes in histopathology. So, the disease is medulloblastoma. So, what are the types of rosettes seen in medulloblastoma, my dear friends? These are Homer Wright rosettes. Those are true rosettes or false rosettes. Those are false rosettes with the central core filled with the neutrophils. So, Homer Wright rosettes with medulloblastoma, child plus cerebellum plus rosette. Again, my dear friends, you don't need to read entire series of pages or textbooks for this. You just need to have the clinical integration and clinical snippets of the type of presentation of the tumor. Then you can reach the diagnosis of the question very easily. Child plus cerebellum plus rosenthal fibers is pilocytic astrocytoma. Yes, my dear friends, cystic tumor in the cerebellum with rosenthal fibers on histopathology is pilocytic astrocytoma. Child plus cerebellum plus rosette is medulloblastoma. Child plus cerebellum plus rosenthal fibers is pilocytic astrocytoma. Child plus precocious puberty plus suprasellar calcification, classically seen in craniopharyngioma. Again, my dear friends, you don't need to know about true palisading here. You already got the diagnosis based on the clinical picture. So, history and clinical examination is always more important than the slide or the histopathological findings. Don't get baffled by seeing the histopathology slide. So, young boy plus sensory neural hearing loss plus vertical bodies. Classically, plus cerebellopontine angle tumor, it is acoustic neuroma or schwannoma. Young boy plus seizure plus headache, but plus Friedreich appearance and chicken eye vasculature of the tumor. Again, my dear friends, it is classically oligodendroglioma. Child plus headache plus ventricular tumor plus true rosette. Again, my dear friends, in the entire histology, true rosettes are only seen in ependymoma, and ependymoma are ventricular tumors. Young male presenting with seizures with intractable headache plus pseudopalisading. Again, my dear friends, a tumor more common in the children and more common in the males. Young male presenting with seizures and intractable headache. Intractable headache indicating something malignant and something more spreading, and pseudopalisading, it is classically glioblastoma multiforme with classically butterfly appearance, crossing the midline, and the features of more malignancy, and the prognosis is usually poor in glioblastoma multiforme. Female in the reproductive age group presenting with headache plus Horald pattern. Female plus headache plus Horald pattern is meningioma. Again, my dear friends, whenever you hear the word Horald in meningioma or mesothelioma, you must think of psammoma bodies. And again, whenever you think of papillary tumors have psammoma bodies. Child plus leukocoria plus squint plus Flexner Wintersteiner rosettes. Classical picture of retinoblastoma. The first symptom of retinoblastoma is leukocoria or white eye, and the second symptom means squint or strabismus. So that's all, my dear friends. These are the clinical snippets which help you in diagnosis of the rarest of the tumors. But again, my dear friends, I would like to emphasize that history is more important in making a diagnosis of any brain tumor or any clinical question. So pay more attention on the history, and then you can reach the diagnosis and you can correlate with the neuropathological findings. So have fun reading. I'll be back with more clinical snippets very soon. Thank you, my dear friends.